Thank you for inviting me to join your annual National Tribal Public Health Summit. This is my first appearance at the summit as CDC Director, but I can assure you it will not be my last. I know I have said it on previous occasions, but I think it bears repeating here. Maintaining the integrity of our government-to-government partnership is very important to me. I am deeply committed, as is all of CDC, to the health and well-being of American Indian and Alaska Native tribes. And while I could not be there in person, several CDC senior leaders, including Dr. Celeste Phillip and Nate Smith, are participating in the listening session during the summit to note all of your comments and concerns about the partnership and how we can work better together. The COVID-19 pandemic has had a disproportionate impact on Indigenous people, particularly American Indian and Alaska Natives. I want to start by expressing my deep and sincere sympathies for the impact and loss that this pandemic has had on your tribes. The loss of tribal leaders and elders has had a deep impact on culture, knowledge, stories, and language. I am deeply sorry for what your tribes have been through and want to convey to you my support to all of you during this difficult time. Historical trauma and persisting racial inequities have contributed to disparities in health and socioeconomic factors in your communities. Again, we can and must do better. I have promised from the start of my tenure as CDC Director to make sure the agency always leads with science, transparency, and equity, and I am a woman of my word. I strongly value open communication and transparency. Focusing on equitable access to care, reducing barriers, and increasing engagement allows us to build trust in tribal communities. To that end, we gladly partnered with the National Indian Health Board to produce the Indian Country Capacity Scan that takes a comprehensive look at tribal public health infrastructure and activities. The report focused on immunization, screening, prevention, and educational activities across Indian country. This data-driven survey will help us measure how public health is supported, maintained, and advanced among American Indian and Alaska Native populations throughout the United States. Another demonstration of our support can be seen in CDC's cooperative effort with the Working with Tribal Nations training developed by the National Indian Health Board. CDC staff worked right alongside tribal leaders, as with other federal, state, and non-tribal stakeholders, on the training program designed to elevate tribal health care and public health needs, and to improve public health collaboration with tribal governments. CDC's support of tribal health can be calculated in other more material acts as well. We are making direct investments in our commitment with significant increases in funding and more technical support for the most urgent issues. In 2020, CDC and AATSDR provided approximately $247.1 million in direct funding to tribes and tribal organizations, approximately $208.7 million of which was allocated to support tribal communities in direct response to COVID-19. A multi-year grant of nearly $20 million is provided through the Well-Integrated Screening and Evaluation for Women Across the Nation program, otherwise known as WISE Women, to reduce the risk of heart disease and stroke among tribal women. This program brings together 3 tribal organizations: the Native American Rehabilitation Association, Southeast Alaska Regional Health Consortium, and the South Central Foundation to provide women with the services and community support to encourage lifelong heart-healthy living. The COVID-19 pandemic has opened our eyes to glaring health inequities that have long plagued our nation. It has had a devastatingly disproportionate impact on communities of color. Tribal countries have been especially hard hit. The pandemic illuminated a much older, more deeply entrenched epidemic impacting public health: the epidemic of racism. Declaring racism a serious public health threat forces us to reckon with racial and ethnic health disparities that are severe, far-reaching, and unacceptable, and we are not stopping there. We are taking it a step further to finally address racism as a driver of health inequities through a wide range of key initiatives, including massive funding. We have committed $2.25 billion for COVID-19 related health disparities among racial and ethnic minority groups and people living in rural areas. We have dedicated another $3 billion to support local efforts to increase the use of vaccines by those disproportionately affected by SARS-CoV-2. One of my priorities as CDC Director has been the allocation of adequate funding to support a wide range of public health activities in response to COVID-19 in Indian country. Over the past year, CDC has provided $208.7 million to tribal nations, tribal consortia, and tribal serving organizations for COVID response. In using a multifaceted approach in the allocation of funding, we hope to enable broader access to COVID-19 resources across tribal communities. We heard your concerns about the competitive process among tribes for CDC funding. We worked to make funding more accessible with a non-competitive grant. $142 million of the grant, supporting tribal public health capacity in coronavirus preparedness and response, was made available in flexible funding to 346 tribal recipients. Grantees tell us the funding will reach more than 290 tribal nations, 25 tribal consortia, and 31 tribal organizations, which will reach more than 490 tribes and more than 39 million individuals, according to Grantees' self-reports. Tribes have been able to use this funding for a wide range of COVID-19 response activities. For example, Chickasaw Nation is using these funds to set up multiple tent sites that offer COVID-19 testing and vaccination across the 13 Oklahoma counties in their service area. They have been also able to purchase a 40-foot mobile medical unit with a mobile X-ray system and vaccine cold storage. The Manilac Association, which covers 12 tribes in northernmost Alaska, has used the funds to increase emergency operations and laboratory capacity in that area. They purchased temporary structures to house COVID-19 patients, create isolation areas, and do COVID-19 testing. These funds have also enabled them to purchase equipment and software to provide same-day COVID-19 testing results. Also, through this grant, the Wichita and affiliated tribes were able to purchase a mass communication system that sends out COVID-19 emergency alerts, along with other prevention, education, and compliance messages. The system also lets them map COVID-19 cases and visualize the spread of COVID-19 at state and local levels. In addition to increased funding, CDC's COVID-19 response has deployed 289 staff to the field in Indian country to support hands-on technical assistance. We have also provided 2 remote deployments and 18 hybrid deployments to support this response in tribal communities. A dedicated tribal support section within CDC's COVID-19 response provides many things, including case investigation and contact tracing, community mitigation, surge staffing, epidemiology surveillance and mapping, data analysis, water, sanitation, and hygiene support, and response, planning, protocol, and policy guidance. In addition, we have worked with federal and tribal partner agencies to create tribal-specific COVID-19 resources, such as data-related resources, training, toolkits, and communication and guidance templates. We have also been sharing COVID-19 case surveillance data with the tribal epidemiology centers for the past year to assist in their data analysis efforts. There is a dedicated webpage on our CDC website that highlights these resources, including guidance documents. Despite repeated infectious disease threats over the past 10 years, you and I know that our public health infrastructure was not prepared for the COVID-19 pandemic. We simply had not invested enough resources. We also know there will be other threats down the road. It is not enough prepare for 2022. We must look ahead 20 to 30 years to plan for the next public health threat. A 5-year cooperative agreement, the Tribal Public Health Capacity Building and Quality Improvement Umbrella, enables CDC centers, institutes, and offices to award funding to 25 tribal nations and organizations to optimize the quality and performance of tribal public health systems. Another 5-year cooperative agreement, the Strengthening Public Health Systems and Services through National Partnerships to Improve and Protect the Nation's Health, will enable CDC national partners to work towards sustaining and improving the public health systems with an emphasis on state, tribal, local, and territorial health departments. Additionally, $2 million in CDC funding to 11 tribal epidemiology centers will help to increase their capacity to deliver public health services to and with the tribes and villages in the HIS area. This includes added epidemiologic surveillance and public health data infrastructure. Also, through this funding, tribal epidemiology centers are providing technical assistance to tribes and key partners to assist in data collection, use, and sharing. CDC also invested approximately $560,000 in the Public Health Associate Program, or PHAP, to fund work in tribal host cities or in tribally focused assignments. More than a dozen associates from CDC's PHAP supported tribal public health in a myriad of program areas, including chronic disease prevention, environmental health, and emergency preparedness. Shifting to focus on vaccines, I want to take a moment here to congratulate your tribes on an incredible vaccine effort. Tribes are doing such a phenomenal job getting members vaccinated that you are outpacing other areas in the rate of vaccine. You have been so successful that, in some cases, you have been able to reach out into communities beyond your territories to assist with vaccinations there. I want to thank you for your efforts. Your ability to get vaccines administered will save lives. We listen to your concerns about consulting with tribes on the policies and programs implemented by CDC. No one outside of tribal communities can know what is in the best interests of the people in those communities. Only tribes can know that. Our goal at CDC is to support your efforts and establish clear policies that will enhance the government-to-government relationship we so value. Only through clear, open communication between us will we form a mutual understanding and make informed decisions on behalf of Indian tribes and the federal government. CDC's Tribal Advisory Committee prioritizes input and guidance on policies, guidelines, and programmatic issues affecting the health of American Indian and Alaska Native tribes. Our tribal consultation policy requires all agency programs to consult with tribal governments when developing programs, policies, and activities that affect Native people. We are working closely with HHS to gather tribal input through formal consultation while continuing to search for ways to strengthen and engage in open and meaningful consultation. I want to thank you again for the opportunity to share some of my priorities as CDC Director and ATSDR Administrator in working with tribal communities. It is an honor to work with you to improve public health and ensure health equity for tribal communities across the country. Thank you.